So I think when we think of oculoplastic surgery, most of us probably realize that a lot of the surgery we do is done with sutures and cutting and tying, and what really has changed in the last 20 years? I would say probably 80% of what we do can be done with very low-tech things. So this talk is going to focus on the 20% of where we have improved. We've seen improvements in all fields of ophthalmology. That talk we just heard on flaps, and I think that's come a long ways, and we do have some things that make us better surgeons. So if we look at the technological spheres of what influences our patient care, we see improvements in materials, in medications, communication between doctors and patients, software and hardware all lead to better patient care. But I think the question is, how do we adopt these changes? How do we make things better? A lot of times there's resistance to change. Unless things lead to better outcomes, shorten operating times, give less complications, probably we're okay with most of what we do. This is a quote from a French philosopher: "Modern technology is no longer an option, but a necessity imposed on all human activity." And I think we see this on our day-to-day lives. So just out of historical context, some things don't change. However, it does help us to see the bigger picture. In 1758, the Code of Hammurabi says if a physician makes a large incision with an operating knife and cures and opens a tumor over the eye, he saves the eye, he receives 10 shekels in money. Most people, most historians feel that this was referring to dacryocystitis. And I would say probably, since the Code of Hammurabi was written, most of us would do the same thing. We'll drain it and patient does fine. But 10 shekels now leads to about $2.68 in US currency. But this is the type of thing where this standard of care has not changed. We're going to switch gears and talk about where things have changed. So orbital implants is one where we have seen a lot of changes, like lens implants. Probably most of you doing cataract surgery now, the lenses are completely changed what you did 20 years ago. So there's a trend from one size fits all that we saw very early on to now having very custom patient-specific implants. And when I think of how I would describe how orbital reconstruction has changed through the years, I kind of think of this as software. There was version 1.0, and then there was version 2.0, and version 3 and version 4. So version 1, which was kind of still used, is where the surgeon takes a sheet implant and cuts around the edges and puts that in, and that's the implant. Version 2 is where anatomic reconstructions of implants were made, but still fabricated in a stock fashion. It wasn't patient-specific. It still may need modification, but at least the surgeon is not having to rely on cutting and shaping things. Version 3, which is currently in place, is patient-specific implants. So these are implants that are made like a hand in a glove, a custom glove that fits this implant perfectly. And I'm going to make a prediction, probably version 4 at some point will be, we're not even using implants. We're using patient stem cells. If you harvest either fat-derived stem cells or bone-derived stem cells, we can grow these in the lab and make an implant where we don't even need to use other materials. So that's not quite being done yet. At least in the US, the FDA very strictly regulates what we can manipulate in the lab, even though it may be better. That's still not quite FDA approved. So this is a version of 1.0, and probably Santosh will agree with me, for fractures, this is still 80 to 90% of the way we fix these things. You take a sheet implant, you cut it, and you fit it into the hole. You make it in the configuration that's needed. And some of the implants that have been used in the past, MedPore, Supermid, Teflon, silicone, titanium, it doesn't really matter what implant it used. However, what does matter is where the implant is placed and is it placed properly. So most of the time in orbital floor fractures, you have to rest the ledge of the implant on this little tiny bone called the palatine bone. If you look at the cross-sectional 3D scan here, right where that arrow is where that implant has to sit. Otherwise, it can tip down and you get problems of the implant not resting properly and the eye will collapse. This is an example of exactly what I was talking about. The implant material was placed such that that little posterior ledge was not abutting that palatine bone. And you can see that this patient had a very poor reconstruction, had a lot of enophthalmos after surgery, which required removal of the implant and placement of a new implant, and the patient had a pretty good result. This is an example of a version 2 implant where there's a complex defect, and you can see this gentleman lost his eye from a shrapnel accident. Very large defect that would be hard to kind of shape a two-dimensional structure for that. You can see a lot of this bone is comminuted. And this is an example where a prefabricated stock implant is made. This is what's called a MedPort 2/3 orbit. And it gets probably the average size of an orbit. It's not patient-specific, but you can take certain aspects of this stock implant that's sterilized and fashion it such that you can create a pretty good approximation of this defect. So this is this gentleman before surgery. Here he is after taking a little aspect, and I circled kind of where this implant was taken, and we fixate that with titanium, and you can see it does a pretty good job of creating a reconstruction of that rim implant. Well, version 3 which is probably where we at the highest level of technology currently, are patient-specific implants. So this is where we take a 3D image and it's mirrored off the normal side. So if you look at this on slide left, you'll see this area in red. Red is the area of the defect. So the normal the normal side of the CT scan is mirrored and flipped, and then any sort of missing tissue is made up by this red implant. So this is a custom implant that fits hand in glove into the defect of the patient. This is an example of where this looks like on fabrication, on a 3D modeling, and then this is what the implant looks like when you do the surgery. And what we receive at the time of surgery is a custom acrylic skull with the implant, and then the implant can be trimmed or shaped as it's fit into place. A good example of this is when we saw this gentleman recently who had neurofibromatosis. And you'll notice that he has the typical S-shape upper lid, which is a plexiform neurofibroma. But the thing that bothered him the most was this pulsatile exophthalmos that we see. It didn't really affect his vision. You know, these are children who are living with their whole life, so their vision is adjusting to this motion artifact. But what he didn't really like was this bulging, this pulsatile that he felt drew extra attention to him. And it was a long discussion whether or not we actually try and fix this, because it required a combined procedure with our neurosurgical colleagues, but he felt that he was bothered enough to have this done. So this is where the 3D implant came on very useful. This is his scan, preoperative scan. You can see that he's missing his greater wing of the sphenoid. He also has missing some of his lateral orbital rim. This is what his prefabricated 3D implant looked like. And again, this would be very hard to model by hand, either using bone grafts or other materials, but it's a perfect example of where a 3D model would fit in. He underwent a combined procedure with neurosurgery. We were able to reposition his eye, and we were able to actually preserve his vision and his motility. It's always a risk of that when we go in through these larger incisions with the possibility of bleeding and perhaps infection. But here he is post-operative. And you can see that it's done a great job. Maybe just a small bit of pulsation, but much better to where he was before, and he was very happy. So these are implants that are not needed in every case. I think standard implants do allow you to perform fairly rapid surgery if needed and get a good result in most of the time. These complex cases, we do need a little bit of preparation to prepare a patient-specific implant. It takes a couple of weeks to fabricate it, but they are useful in these more complex defects. Let's talk about what's available in probably most of our hands and pockets nowadays. Smartphone technology. Probably 90% of the population in the US and probably here in India have smartphones. It's a readily available pocket tool. It's useful for many applications. We may take photos of our patients. We may text each other about how to manage patients. Our EHR, electronic record, is also available on our phone. One use that probably is somewhat neglected by at least oculoplastic surgeons that I speak with is the slow-mo mode on the camera. So this is 240 frames per second capture. Let me go through a recent patient that I cared for. This is an 82-year-old gentleman who presented with bilateral ptosis. He also had pre-existing lid retraction. We can see he's probably a setup for exposure, right? If we do surgery on him to fix his lids, what about the lower lids? He's actually probably a little, has dry eye pre-existing. So we performed bilateral external levator advancement, lower lid ectropin and retraction repair. He also had previous cataract surgery and eye stent procedure. So how do we actually judge the risks of developing exposure preoperatively? What are the common tests that we look at? Well, we look at Bell's phenomenon. Does the eye roll back up when on attempted eye closure? We look at the presence of lag ophthalmos. Is the patient going to have some pre-existing risk of developing this? Orbicularis function. Sometimes the blink strength is not adequate. And then we look at other things such as Schirmer's testing. We check the corneal sensation. How many people in the room look at blink rate or completeness of blink? Anyone look at that? Okay, we got a couple hands going. I have to say it's not something that I look at routinely, but it's something I do notice. So people that blink very frequently, they're worrisome because they probably will, they're set up for dry eyes. The ones that don't blink are the ones that are equally worrisome because they probably have neurotrophic keratitis and they can't feel anything, so they just keep their eyes open all the time. So one use for this measuring of blink rate and completeness of blink is with the 240 frame per second camera. So this is something that we published a few years ago. Use of blink dynamics. It's something you can pull out of your pocket and film the patient. Just to give you an example of how useful this is a playback of regular speed of a person blinking. This is one of our fellows actually. Maybe the blink rate's a little fast. Let me play it a few more times for you. Back that up. Blink's a little fast, but are any of you detecting anything wrong with that blink other than it maybe being a little fast? Okay, well let's look at the same blink on 240 frames per second. Not blinking all the way. You see the inferior part of the cornea is not being covered? So this is something that's not detectable to the naked eye. It is detectable on 240 FPS. So it's a good way to measure the completeness of, assess blink rate and blink coverage. So we operated on this gentleman, and you can see here he is postoperatively. His lids are still fairly swollen. His upper lids are not quite where we want them to be with the ptosis repair. And even on lag ophthalmos, he has complete closure. But he started to develop these corneal defects. He had bad SPK, which turned into gross epithelial defects. So, you know, I pulled out my camera, and I luckily had filmed him before, so I knew this, but I want to show you what it looks like on blink rate after the surgery. So this is him blinking now after surgery. So you can see with his blink, he's not even covering his cornea. So this was an exact cause for the findings we were seeing on his cornea. They were dry, he had gross epithelial defects. So the way we treated this was we used temporary tarsorrhaphy. I just put a suture tarsorrhaphy for 2 weeks. We used bandaged contact lens. He did well. So the other thing we have to think about in a postoperative patient is the orbicularis gets paretic. You're right there, it's bruised, it's healing. We just gave anesthetic. Probably as the orbicular strength recovers, his blink will get better. And he ended up doing well, his cornea healed. But it's a good way to assess blink rate and blink dynamics. So make sure you have that handy. Most people have smartphones. It's available on your phone. Let's switch gears a little bit and talk about targeted therapy. So thyroid eye disease is something that we have treated for decades, mainly with steroids, some radiation. Surgery has been the mainstay for treatment of this. In the US, we do have the availability of about 4 years now of this targeted therapy. So there is a monoclonal antibody that is marketed for binding of the IGF-1 receptor. So thyroid eye disease is thought to be driven by binding of stimulating autoantibodies to the TSH as well as the IGF-1 receptor that are co-localized. And when these two antibodies bind, it leads to two different processes. One is hyaluronic acid production, which goes into the extraocular muscles. The second thing is orbital fat proliferation. Just to give you an example of how we can use this targeted therapy for our thyroid patients. This is a 45-year-old female who was diagnosed about 2 years prior to when we had seen her on methimazole for her hyperthyroid status. She's a non-smoker. She was treated previously with pulse steroids, however it recurred. She has exophthalmos, and she has a CAS score of 6, so she has lid swelling, erythema, conjunctival injection, and she also has painful eyes. On examination through imaging, we can see enlargement of almost all four. The superior, medial, inferior rectus are large. The lateral may be spared. And certainly on axial view, we see something very similar. This is her after undergoing 8 infusions of teprotumumab. So it's very targeted therapy. It allows reduction of proptosis, reduction of the eyelid edema. And she did well after. She didn't need any further treatment. Sometimes patients do relapse. They need surgery or other immunosuppression. There has been some side effects that have been reported: nausea, cramps. One of the more common things that we hear now is hearing impairment. So anytime we discuss this treatment with patients, we do have to mention the possibility of hearing impairment, elevated glucose. It also should not be used in childbearing women unless they're on contraception. As we wrap up here, I'm going to cover a couple more things. Understanding of the aging process. So we're seeing more and more patients now live into their 90s. This happens to be a 90-year-old patient that came in. And she wasn't really concerned so much about this hollowness in her lid, but she did say, I have this little bulge in the inner corner of my eye. What can you do for this, doctor? So what we're seeing is that there's differential aging that occurs in the orbit. The preoperative fat in front of the levator, this yellow fat tends to atrophy with age. The whiter nasal fat tends to be preserved, if not a little bit more larger. And this is a common aging pattern that you see. I bet if you start looking at your patients more carefully, you will see this as well. You start to see this prominent nasal fat pad and maybe not so much in the central. It's very clearly different in color. This is the nasal fat pad. The central is more yellow. We looked at a study just kind of graphing what happens to this fat pad. In red is by decade of life. The nasal fat pad is preserved. The blue, which is the central preoperative fat pad, gets more thinner and atrophic. The changes occur in about middle age, 40 to 50. Why does this happen? We did some immunohistochemical staining of the fat. We found that the nasal fat pad had a higher CD34 rate. Well, what does that do for us clinically? We rarely take out preoperative fat. Now, if I do an upper lid blepharoplasty, I'm going to preserve that yellow fat as much as we can. The nasal fat pad, we can remove it judiciously, and if we ever need it for grafting, it probably will do a little bit better with survival. I don't think any talk nowadays at least would be complete without at least a mention of AI. You guys have probably all heard it. And it's something that I think is going to be here to stay. How it applies to medicine, we're not sure. I played around with it a little bit. I took one of these old visual fields. Probably the older physicians here in the room will know what this is. This is a Goldman visual field. And I plugged it into the free version of Claude, which is AI, and it says, this appears to be a visual field called a tangent screen or Goldman, so it figured it out. It also said that it appeared that the solid line and the dotted lines were different, and it was probably from a lid field. So we do these lid fields where we test patients to see how much improvement there would be with taping of the lid. It also I asked it to quantify percentage-wise how much difference in percentage was, and it did it quite well. One thing that we are experimenting with is how do we use AI to respond to patient messages. So for those of you on an electronic record, it's common now for patients to message the doctor. And we get flooded with 50 messages a day because it's very easy to type in a little text to your doctor as opposed to calling and waiting online. So we did some studies as to how we could use AI for this. Well, a couple of things were interesting because we had human messages that we were using as a control, and then we sent AI messages out. And interestingly, the chatbot, the AI, was judged to be more empathetic than the doctor. It actually, said different things. It empathized a little bit more. We just looked at 2 different studies for us, and we looked at the Google product versus the ChatGPT. For us, we found that the ChatGPT was a little bit more empathetic than the Google version. anyways, so that's just a little brief discussion on that. We didn't see this hallucination that can occur. You know, sometimes the AI gets so confused it has no idea what you're talking about. In fact, one of the in the publicly available literature, ChatGPT recommended discontinuing glaucoma drops and using allergy drops for allergies. So, in summary, we've seen a lot of tech advances, implants, smartphone technology, targeted therapy for thyroid eye disease, understanding with the aging process. When we get the intersection of art and science is when our patients benefit the most. And I'd like to thank the UKSOS and the AIOS for giving me this great honor. Thank you very much.